So as most of you know, acute myeloid leukemia is a disease resulting from the clonal expansion of myeloid blasts. And this disease is clinically, morphologically, and genetically very, very heterogeneous. Untreated, it is deadly within a few weeks or months. And the first cures were actually achieved in the 1960s with first chemotherapeutic agents, namely cytarabine and anthracycline. And today we do that not much different. The induction for AML patients is still consisting of cytarabine and an anthracycline. Most of the benefit that today's AML patients have is due to the improvement of supportive medical care. So why would we need molecular markers? Why is molecular profiling important in AML? Why are mutations important in AML? Why is gene expression important in AML? Well, for once, if you look at the 2016 revised version of the WHO classification, it is obvious that, first of all, you need cytogenetics to classify AML correctly, but you also need mutation status because, for example, AML with mutated NPM1 is an distinct entity. AML with biallelic mutations of the CBP alpha gene is a distinct identity, and also there's a provisional entity called AML with mutated RUNX1. So mutational profiling is important, let alone by the WHO classification. This is also reflected in the very recent ELN 2016 genetic risk classification. So if you want to do risk stratification according to the ELN guidelines, you also need the mutational status for your patients. You also need at least the NPM1 mutation status. You need to know whether they are FLT3-ITD positive or negative. And with the new stratification, even if what the ratio is, FLT3-ITD to wild type, and you also need the CBP alpha mutation status. So without these mutations, you basically can't classify your AML patient. Another thing is that all the biological insights that we have gained over the past years has led to the development of new therapeutic agents. This is led by the development of FLT3 inhibitors. Last year, the Myeloid paper came out, which was basically the first targeted therapy option that actually led to overall survival benefits in AML patients since basically the introduction of induction therapy. But there's a lot of other targets, there's a lot of other pathways that can be exploited and that are being tested in clinical trials right now. So knowing what kind of mutation, what kind of gene expression profile the AML patients has will help in the future to decide what treatment to give to the patients. I want to focus on two things that are basically today applicable in the clinic for us. First is the evaluation of measurable residual disease during disease course. And then I'm going to show you two examples. For one, for AML-associated mutations such as the NPM1 gene. So I'm going to show you the NPM1 gene. I'm also going to show there are also AML-associated gene expressions such as BALC, MN1, WT1. There's also EVI1. There's a lot of genes that are associated with AML. And there's also potential targets for anti-leukemic therapy, like for FLT3-ITD, FLT3-TKD, and relatively new IDH inhibitors, which have proven in clinical trials to be pretty potent. So first I'm going to talk about measurable residual disease with an example of the NPM1 mutation burden. And then also I'm going to talk about AML-associated gene expression with an example of MN1 and BALC expression and how we can use them to risk stratify patients and probably guide future treatments for our patients. So why do we do a measurable, or when can we do measurable residual disease? Basically, we measure the burden or the presence of the mutation at diagnosis, and then we can measure the same thing during disease course, so after induction, after consolidation, including, of course, allogeneic stem cell transplantation if the patient is able to receive an allogeneic transplantation, and then during follow-up. When to do that, at when time point, and also from which material the measurable residual disease is taken is still up to debate and is still not very clear. what you basically do is that you can, with the measurable residual disease, you can measure the leukemic burden that is still present in the patient. And this gives you a benefit of sensitivity, because if you see this area here, this is basically what can be covered by morphologic assays like cytology. You do not go deep enough. You don't gain the sensitivity. You basically can have a patient in CR, but there's still a lot of leukemic burden left, and the potential of minimal or measurable residual disease is that you cover this area here. So you can basically go deeper. You can go more sensitive, and you can detect relapse earlier, and you may even detect patients that are molecular in complete remission. So with the help of measurable residual disease, you can predict potential clinical courses like early relapse, late relapse, or long-term remission. And that will help in the future to guide treatment. My first example of a very common gene that is used for MRD measurement are NPM1 mutations. Why are NPM1 mutations used for MRD measurement in AML? For one, they are pretty frequent. Approximately 40% of patients have those NPM1 mutations. Second, it's rather stable during disease course. So once you have the NPM1 mutations, you also have it during relapse, and you will not lose it during disease course. There's only a very, very few patients that lose this mutation during disease course. This protein is generally ubiquitously expressed in tissue. However, the function of it is not very well defined yet. At first, I want to show you what we did with our NPM1 mutated patients that we actually transplanted. So I give you an example of 46 patients with a median age of 64 years with material available prior to transplantation. All those patients have been in CR or in CR with incomplete peripheral recovery. They all were NPM1 mutated at the time point at diagnosis, and we could not detect the NPM1 mutation at time of transplantation with traditional PCR-based methods. So when you do this, you get a pretty strong prognostic marker for those patients that will eventually relapse, even though they have been transplanted in complete remission or in complete remission with incomplete peripheral recovery. So basically all patients that were MRD positive for NPM1 mutations at time point of transplantation relapsed, and this also translated in a significantly shorter overall survival. We can also follow the NPM1 mutation burden during disease course. So we can look at the mutation burden at time point of diagnosis and then during disease course. And here I brought you an example of the NPM1 mutation burden of a patient that basically got diagnosed here with a very, very high burden. It was lower than after induction and consolidation therapy. He then experienced a first relapse, then had a salvation chemotherapy, and finally an allogeneic stem cell transplantation, where at day 28 post the transplantation he was the first time negative for NPM1 mutation. This all is of course retrospectively. Then retrospectively at day 56 we measured again and we found that the NPM1 mutation burden was rising to this time basically of almost 4 log increase of the NPM1 mutation burden, but the hematological relapse appeared at day 70 almost. So with measuring NPM1 mutation burden during disease course, you can predict a frank hematologic relapse. I also brought you a more positive example. So this is a patient that basically got diagnosed again with very, very high NPM1 mutation burden at diagnosis, and then rapidly decreased this burden to not measurable anymore, got a transplant in first complete remission, and is still in ongoing CR with no measurable NPM1 mutation burden. What we also did was we looked at AML-associated gene expression markers, if they could be helpful for those patients that do not carry recurring mutations that are easily measurable by real-time or digital droplet PCR. And we first looked at a gene called brain and acute leukemia cytoplasmatic BALC, which is expressed in early hematopoietic progenitor cells, and it gets downregulated with differentiation. However, BALC function in hematopoiesis is not fully understood, but there's evidence that it blocks myeloid differentiation. Together with a second molecular alteration, it provides a proliferation advantage, and BALC may contribute to AML leukemiogenesis. What was known so far was that high BALC levels at AML diagnosis have been shown to impact patients' outcome adversely. And our hypothesis was that high expression levels at the time point of e.g. transplantation would basically predict relapse. So what we did was we looked at 82 AML patients with a median age of 64 at hematopoietic stem cell transplantation. We only took peripheral blood to measure BALC in those patients close to the transplantation. Again, all those patients were in complete remission or in complete remission with incomplete peripheral recovery, so there was no evidence for AML morphologically. And what we did is, so here you can see the distribution of the BALC expression in peripheral blood of those patients prior to transplantation. We also did a healthy control panel, which was age and sex matched over here. And we used an R package called optimal cut points to define an optimal cut to distinguish patients with high expression and a higher chance of relapse from those that have low expression with a lower chance of relapse. And this cutoff was higher than any of the measured healthy control standards. And when you do this, you basically get also a higher cumulative incidence of relapse for those patients at time point of transplantation express BALC at high levels in peripheral blood compared to those with low expression. And that also translated into shorter overall survival. So by measuring BALC at time point of transplantation, we can identify patients with a higher chance of relapsing after transplantation. And that will lead to a closer monitoring and could basically, in future clinical trials, lead to trials that would test faster immunosuppression tapering, for example. What we also looked at was if those patients that have higher expression at transplantation would not only relapse, but relapse faster. And we could see that by trend, they actually relapse faster. So those with a high expression of BALC in peripheral blood at time point of transplantation relapsed by trend only, so that it didn't reach statistical significance compared to those with low expression of BALC. However, if you look at the first 100 days after transplantation, those with higher expression had a significantly higher relapse rates than those with lower expression, and that was also true for the first 6 months after hematopoietic stem cell transplantation. So that indicating that this p-value would probably get significant once we've reached a sufficient number of patients. Another gene that we studied is meningioma 1, which is located on chromosome 22, and it's also expressed in hematopoietic stem cells and downregulated during differentiation. It was also found that this gene, if highly expressed, it's highly expressed in acute lymphoblastic and myeloid leukemias. It's also associated with worse outcomes when it's expressed highly at time point of diagnosis. So we did the very same thing that we did with the BALC gene, and we also used the same program to define a cut point here, which was again higher than the healthy control standards that we've seen. And this time we could also manage to actually build in a second cut point to isolate the topmost patients with the highest expression of MM1 at time point of transplantation. And if you do this, you get a very similar curves. You also get a much higher incidence of relapse for those patients that express MM1 at higher levels at time point of transplantation in peripheral blood compared to those with low expression. Which the curves separate, but the p-value hasn't reached statistical significance. And if we used our second cut point there, you can see that these with the topmost expression of MM1 copy numbers, even though those patients were in complete remission at time point of transplantation, had a very, very high chance of relapsing after transplantation, with also here in the overall survival curve, even though the p-value is not significant, the lowest running curve. So in conclusion, for minimal or measurable residual disease, NPM1 mutation, BAL-C, and ML1 may be used for MRD evaluation prior to an allogeneic stem cell transplantation and likely during disease course. They are independently of other clinical and genetic prognosticators, even though I've not shown you that. We've tested this in multivariate analysis. The analysis of MRD prior to transplantation and also during disease course may guide treatment decisions in the future. And of course, prospective studies are needed to determine treatment strategies in MRD positive patients, e.g. the addition of additional chemotherapy prior to transplantation, or faster tapering of immunosuppression, or even treating those patients with prophylactic or DLIs. So, coming to the second part of my talk, I'm going to talk about targeted therapies. And as examples, I'm going to talk about FLT3-ITD and FLT3-TKD. I'm not going to go into too much detail here because I know that there's going to be a talk after me that will talk about FLT3-ITD or TKD positive AMLs. So I'll quickly skip through this. Targeted therapies are part of standard treatment protocols in many hematologic malignancies like CML, APL, and also non-Hodgkin's lymphoma, for example. Until today, it's only limited use in AML. There are some tyrosine kinase inhibitors like sorafenib and now newly approved midostaurin, but they are all very limited in their efficacy. There's also targeting antibodies like CD33, which may also be effective, but maybe only in a subgroup of AML patients. So very, very briefly, FLT3 has an important function in healthy hematopoiesis as well as in leukemogenesis. There are internal tandem duplications that are present in about 20% of AML, and more frequent so in cytogenetically normal AML. They are usually associated with adverse prognosis, especially in patients with a high mutant to wild type ratio. And patients with FLT3-ITD seem to benefit from an allogeneic stem cell transplantation. As opposed to NPM1 mutations, those mutations are not stable during disease course and represent not a very suitable marker for MRD. They may actually appear newly in relapse or even be altered in relapse. So you may have a different FLT3-ITD at diagnosis than you have at relapse. However, there are very, very effective FLT3 inhibitors that entered clinical studies. One that has been approved now is midostaurin, and I'm gonna just quickly skip those slides because probably those slides will be in the next talk as well. But midostaurin was the first TKI that was approved for FLT3 mutated AML, and it was the first to actually show a survival benefit for patients. I just want to go briefly and talk about two other substances. One is quizartinib, and the other one is gilteritinib. Both are agents that target FLT3-ITD and FLT3-ITD and TKD. These are two studies that we in Leipzig took part in, and I want to give you two examples of how those agents may actually help to improve the therapy of our AML patients. The inclusion criteria for both trials were quite normal. For quizartinib, you have to have a FLT3-ITD positive AML without a FLT3-TKD mutation, because the FLT3-TKD mutation actually represents a resistance mechanism for the FLT3-ITD positive AML. For gilteritinib, you might have a FLT3-ITD positive or FLT3-TKD mutation. So very briefly, I want to give you an example of two patients. So patient number 1 was diagnosed with an AML, 80% blasts in bone marrow, normal karyotype, FLT3-ITD positive, NPM1 mutated. That is not uncommon because those two mutations go together. And after first induction therapy, she still had 16% blasts in bone marrow. She got a reintroduction with a mitoflex cycle. and still had over 5% blasts in bone marrow. So we decided to give her a second mitoflag, from which she recovered with a leukemia-free state and pancytopenia. At which time point we decided to move her on to allogeneic stem cell transplantation following a FLAMSA protocol, which is a conditioning protocol for high-risk AML. After this, it was the first time that she reached a complete first remission. However, a couple of months later, we saw a relapse, and she had 30% blast in bone marrow and also developed chloroma on her abdomen, back, and eye. So at this time point, of course, you are more or less with the back to the wall, and there's really little treatment options. Fortunately, we took part in the AC220 trial, which is a trial testing quizartinib in relapsed or refractory AML, which basically tested quizartinib against the physician's choice. Here again, so this is how the patient looked prior to the quizartinib treatment. So she had a lid. So this is chloroma of the lid. This is her abdomen with chloromas here. And when I talked to her about the study, and when I discussed with her the option of taking part in this clinical trial, I had doubt that this would basically work, and I actually had doubt that she would survive the weekend. However, after we got her into the trial, and we got her randomized, and she got into the quizartinib arm. After 2 weeks of therapy with quizartinib, all those chloromas basically resolved, and she got way better. So this is what basically an inhibitor of FLT3 ITD can do. It can be a quite potent drug. So with this drug, we got her into a second complete remission. She received a second allogeneic stem cell transplantation from a matched unrelated donor. And in January last year, we could discontinue quizartinib, and she's still in ongoing complete remission. And as another example, I have you the NPM1 mutation burden down here. So as you can see, she never got into negative for NPM1. So this is at the time of CR after first hematopoietic stem cell transplantation. This is first relapse. So we retrospectively never had her in complete molecular remission. And this is after after getting into a CR2 after quizartinib, and since then we could not detect the NPM1 mutation. I want to move on to a second patient. This patient was diagnosed with an MDS, and basically started externally on hypomethylating agents. She received 17 cycles of this. With still 60% bone marrow blast, she was diagnosed with a secondary AML. Externally, they continued with 5 cycles of azacitidine, and that didn't work, and the AML progressed, and she was first presented to our department with oral and skin chloromas, with high white blood cell counts, high peripheral blasts, and high blasts in the bone marrow. And she had a FLT3 TKD mutated AML. So we could enroll in the gilteritinib trial, and here very similar. She also had chloroma on the back. So this is a picture that was taken in our dermatology department. They took a biopsy and diagnosed the chloroma here. And even though this is a bad picture because the angle is not good, but this is just a tag of the shirt. It basically completely healed with only gilteritinib. And so with gilteritinib, we received a complete remission of all chloromas, and we decreased the peripheral blast count after 1 cycle from 68% to 3%. And we continued the therapy, and after 6 cycles, she even had a platelet recovery, and she at least had stable blast counts in the bone marrow. So what I want to say with this slide also is that with those new therapeutic options, be it FLT3 inhibitors or IDH inhibitors, we also have to rethink what we expect from a therapy and what time we are looking at. with those inhibitors like 4FIT3 TKDs and IDH inhibitors, one has to have some nerves also to continue and continue and continue, because you won't get rid of everything like with an induction therapy all at once. So sometimes it helps to continue treating patients. So, and with this last slide, I want to thank you for your attention, and I hope I have sensitized you to the importance of molecular markers.